If everyone could take a seat, we're going to get started in about a minute.
All right, good afternoon, everyone. Thank you for being here. Happy spring. It's so great to see all of you here at the HPC, and some nice warm weather. The last couple of days have been great. So very excited for our meeting today. We'll just say at the outset that we have a little bit of a smaller group here in terms of the advisory council. I know it still feels like a big group, but this is actually, not everyone could attend today. It's a busy week, both in healthcare and in state government, with the House budget and amendments to that. So I think our plan is to have a little bit more of a shorter agenda today, really discussion focused, but we'll hopefully get you out of here by 1:30, and a little bit shorter meeting, and on with your day rather than the usual 2 hours. Before we get started into the actual agenda and work, I think it's worth just quickly going around the room and introducing yourself and your organization, just so that everyone here knows. We also have a live web stream going as well, so people are watching remotely. So good morning, or good afternoon, I'm David Seltz from the Health Policy Commission.
Hi, Colleen Elstermeyer from the Health Policy Commission.
Cheryl Clark, Brigham Women's Hospital.
John Arwin with the Conference of Boston Teaching Hospitals.
Joyce Murphy, UMass Medical School.
Cheryl Pascucci, I'm a nurse practitioner with the chart team at Phase 3 Franklin.
Patty Reyes, Mass League of Community Health Centers here for Gemline.
Good afternoon, I'm Tara Gregorio from Mass Senior Care Association, and thank you for the opportunity to be part of this advisory.
Hi, Lynn Nicholas, Massachusetts Health and Hospital Association.
And Meg Hogan, Boston Senior Home Care, representing Mass Home Care.
Alyssa Vangeli, Healthcare for All, filling in for Brian Rossman today.
Paul Hayes with the Greater Boston Interfaith Organization.
Ron Dunlap, Massachusetts Medical Society, practicing cardiologist.
Hi, Monica Sani, Mass Health here on behalf of Dan Side.
Steve Wallace, Massachusetts Council of Community Hospitals.
Hi, Jeff Gallo, AstraZeneca, representing Rich Buckley today, thanks.
David Mattiotto, Mass Association Behavioral Health Systems.
Dave Spackman, Leahy.
Diane Anderson, Lawrence General Hospital.
Chris Hager, Beacon Health Options.
John Durst, Retailers Association, Massachusetts.
And I'm Don Berwick, a commissioner.
Well, thank you all for being here, and thank you. Great use of the microphones all the way around the room. Really excellent. It helps for the people who are watching remotely that we do use the microphone, so I appreciate that. Before we dive into the business of today's meeting, I'm going to turn it over to the Deputy Executive Director of the Health Policy Commission, Colleen, to just update you all on the Advisory Council and your roles moving forward. And so we'll turn it over to Colleen.
Great, thanks, David. So as we kick off this new term of the Advisory Council, we thought it would be important to reflect a bit here on slide 4 in your packets. I don't know why I'm getting so much feedback. I'll back off a little bit. Here on slide 4 on the purpose of the Advisory Council. As you all know, in Chapter 224 of the Acts of 2012, which created the Health Policy Commission, alongside that created this body, the Advisory Council. And it was envisioned at the time as I can just stop using the microphone and just stop. So it was envisioned at the time as a consultative body to the executive director of the HPC, and as executive director has sort of broad authority to appoint members of the advisory council and to decide on the work of the advisory council. David Seltz will be the first to tell you that we started, David, I, and Lois Johnson, our general counsel, in January of 2013. This body met in March 2013. It was one of the first tasks that we took on to appoint and bring this body to fruition. So Since then, in practice, we've used this body, this advisory council body, for a variety of different purposes. We've had robust policy discussions. Last spring, we had 3 meetings on the issue of provider price variation, which was a highlight of your work last year. We've had guest speakers, we've had HPC staff present, we've had our board members present. We've asked you for counsel and feedback on new programs that we've been bringing to fruition over the past 4 years and initiatives. But the primary purpose of the advisory council is a direct line of communication between you all as our constituency and the HPC staff and our board. So we thank you for that. So moving forward, this is actually a 2017 and 2018 2-year term of the advisory council. We have 31 members here. We do have a few new faces, Tara Gregorio, who introduced herself. We have Meg Hogan, representing Mass Home Care, CEO of Boston Home Care. Is that right? And David Spackman, who's the GC and SVP for Government Relations at Lady Health. So welcome to the group. All your names and organizations are listed here. Just one housekeeping thing. Generally, we do welcome designees if they're from your organization. Just appreciate a heads up to me or David ahead of time if you would like someone to represent you, so we can make sure they have a proper intent card in place. And so that's it on housekeeping. We have 2 more meetings this year. We meet quarterly. A meeting in July, a meeting in November. So mark your calendars for that. The next big event that we'll be having at the Health Policy Commission will be our cost trends hearing in October 2 and 3. So mark your calendars for that as well. And I think that's it for me.
Great. Thank you, Colleen, and thank you all for submitting your names for reappointment to the Advisory Council and for going through that process with us. We wanted to make sure that you continue to find your participation valuable as we do, and was very pleased by the overwhelming response and interest in people continuing on the Advisory Council. We are always interested in ways that we can connect with you outside of these meetings and help advise our work, so please, of course, feel free to have an open line to Colleen and to us in terms of how we can work together. When we have new staff join us at the HPC, we ask them to stand up, tell us where they came from, and a fun fact about themselves. Tara, Meg, and David, we're not going to do that today, so don't worry. But welcome to the group. So for our little abbreviated agenda today, just to give you a little bit of a preview, my hope is to kind of just give you an update on some of the activities of the HPC since the last time this advisory council met. But really to pause and to take a step back and to seek your counsel and advice on where the Health Policy Commission should focus its energy and efforts in the next 2 years. As you'll see in a little bit, we are engaging in a strategic prioritization process with our board. We've begun this work and begun these conversations and expect that at the next board meeting, which will be at the beginning of May, that I'll be helping to facilitate a conversation with all of my board members around some of the goals and targets we want to set for ourselves as the Health Policy Commission. And I thought this was a great opportunity to, in helping to facilitate that conversation in May, that I could report to my board about what the Advisory Council thinks some of our major strategic priorities should be moving forward. I would say, and I've said this to the board, to date, our focus and guidepost has been Chapter 224, which lays out a comprehensive set of responsibilities and programs for the Health Policy Commission. I'm proud of the work we've done to establish those programs, to establish regs, to establish processes. We have checked off essentially all of the boxes that we were charged with in Chapter 224. At the same time, we know that we have significant challenges still around healthcare cost containment. So for the Commission, we want to be able to make sure that we're focusing our energy and efforts on areas where we're going to be able to make an impact in terms of our shared goals of reducing costs and improving care. And that may mean, we'll continue to do all of our work that's required of us in Chapter 224, but to be able to put a point of emphasis on some things that we really want to prioritize. And so, again, I'm interested in hearing from all of you today about that, and I hope we can actually get a chance where everyone can help weigh in, and we're going to try to summarize that. It's great to have Commissioner Berwick here try to summarize that for the board when we meet next month. So just to step back a little bit in terms of some things that have happened since the last time we met, we've been busy here at the HPC. The first is we did set the healthcare cost growth benchmark for calendar year 2018 at 3.1%. I think we spoke about this process at our last advisory council meeting in terms of this was the first year where the default benchmark dropped a half a percentage point from 3.6 to 3.1. The board had the opportunity to adjust that number back up to 3.6%, pending a hearing and solicitation of input from stakeholders. We did hold that hearing, which was very well attended by many of you. Many of you testified at that hearing. Appreciate that testimony. And I would say the vast majority of the stakeholders who testified urged the commission to keep the benchmark at the more aggressive target of 3.1 and not to adjust it back up to 3.6. I think this was even reflecting the fact that we had not hit the 3.6% benchmark in the last 2 years. There was a great sentiment that this is not necessarily a projection of what we think will happen in the future, but a target and an aspirational goal that the collective public and private entities represented here can all work towards, and that there needed to be continued urgency in terms of the affordability of healthcare for so many consumers, families, and employers in Massachusetts. So I think a great sentiment that carried forward to my board, and at our board meeting had a very robust conversation. All of my board members weighed in and discussed on this point. And again, I think to feed into our conversation a little bit later, I felt a renewed sense of commitment and urgency in terms of the status quo is not going to lead to a 3.1% healthcare cost growth. And so what do we need to do as a collective state to change and transform in order to meet that goal, while maintaining, of course, our promises in terms of high quality care and highly accessible care. And so I think that's a theme that you'll see a little bit later in terms of our strategic priorities. We also held 2 board meetings since our last advisory council meeting. Some significant things besides the benchmark that we established. We also finalized our regulations for performance improvement plans, which is a key accountability tool under Chapter 224, where individual providers or health plans can be identified as excessively contributing to healthcare cost growth and be required to file a performance improvement plan with the HPC. We have not exercised that authority to date, but had finalized our regulations for doing so. We are expecting to get that next list from CHIA shortly. And then finally, we held, and many of you were at this as well, an event just 2 days ago on consumer preferences, hospital choices, and demand-side incentives, where we presented some new research and findings that HPC staff, in conjunction with Tufts University, Tufts Medical University. Yeah, thank you. All of the above. Had conducted in terms of actually going and talking to patients and consumers about what they value and prioritize in making healthcare decisions, and what type of information would matter most in terms of supporting and empowering consumers and patients to make high-value decisions in care. And so, turning now to the pile of information that's in front of each of you, I'll just kind of walk through some of this for you. You see here our PowerPoint presentation. This is what we'll walk through today. You'll see a press release titled Copays, Physician Referrals, and Quality Ratings, How to Drive Consumer Hospital Choices. This is just a press release and a summary of the event from Monday. You'll see here our blue covered here, light blue. This is our cost trends report from 2016. This had not been published, I think, the last time that we met, but we had discussed some of the findings. So encourage you to keep this by your bedside. You're really going to want to go through all of that. The next piece here, which has kind of a light blue bar at the top, and you can see kind of in shadow, it says chart. So this is just a little 4-pager that we put together that summarizes the first phase of the CHART program, our hospital investment program, and some of the key results and findings from that first phase. We did a full evaluation report. The evaluation report is over 100 pages. We tried to put something together that's a little bit more accessible, so I wanted you to have a copy of that. And then finally, you'll see one final report, which is called Business Report and Fund Statement. This is our operating report for the agency. And so in this report, you can see it has information about the HPC, about our commissioners, about some of our big departments and how we organize our work internal to the HPC, how we organize our staff, as well as information about our budgets and our trust funds that we're charged with administering. So a little bit more of a kind of an operational report, but encourage you, if ever in your day-to-day lives you run across someone who's like, what is the HPC about? What do they do? There's actually a lot of really rich information here that just kind of sums up all the different roles we play in the different departments. So encourage you to take a look at that. So inundated you with paper, typical HPC. I think we can move back into the PowerPoint presentation and begin our conversation and hopefully have a good strategic discussion. So moving to slide 9 in the PowerPoint presentation, you'll see here 4 major policy priority outcomes. Obviously, meeting the benchmark is the central organizing principle of Chapter 224. But underneath that, the law does organize itself rather well around some of these different outcomes that we think will help lead to a system that can actually meet that benchmark. And so I'll run through these really quickly. The first is really around having a well-functioning healthcare market in Massachusetts and having payers and providers being able to compete and to be rewarded on measures of value, of course, which combines cost and quality. The second is around having aligned financial incentives, and this can both be for providers in terms of risk-based contracts and local budgets, but also in terms of consumers and employers that are encouraging them to make high-value, cost-effective care. The third is really about the delivery of our healthcare system and pushing towards a more coordinated and integrated healthcare system that follows patients across that entire care continuum. And the last is around enhancing the transparency and the performance of our healthcare system. So when we think internally at the HPC about all of our different activities and priorities, we try to map them up against some of these different more policy priorities and think, how are our activities helping to push these priorities forward? And it also happens to be the way that we organize all of our recommendations in our cost trend report. And so I'll just quickly move through those recommendations in the next couple of slides. We discussed potential recommendations at our last meeting, but we had not issued the report. So I'm going to move quickly through these. The first category is in fostering a value-based market. And we had 6 sub-recommendations under this category. The first was tracking and monitoring and thinking carefully around healthcare equity and affordability. I think we had discussed at the last meeting some of the HPC's findings in terms of, especially for low and middle income families, that they are increasingly and continue to face difficult affordability challenges. And that we think about developing policies across all of our different continuums that take into account the fact that not all subpopulations have the same access to care, have the same affordability of care, whether that's patients or employers, that we're really thinking about, not just on average, but really some of those important elements in promoting equity across our system. The second was about pharmaceutical spending. Of course, one of a driver that was identified in the cost trends report. You'll see a list of sub-bullets. I won't walk through them here, but of course, increasing some transparency, and specifically, I think we call for transparency around rebates and discounts was recommended. The third is an issue that is a repeat recommendation for the HPC, but is around out-of-network billing, especially in places where consumers have no choice, whether that's in an emergency setting or where they went to an in-network facility but did not know and did not have a choice that one of the members of the care team was an out-of-network provider and maybe stuck with a surprise bill, or that may lead to healthcare increases in healthcare spending. We recommended some policies to address that. On the next page, and I'm trying to move quickly here, but happy to take questions once I get through this. On provider price variation, there was a huge commission that completed its work recently on this, so our recommendation was to continue to monitor variation and to analyze by warranted and unwarranted factors. The fifth recommendation is around facility fees, which is an enhanced payment that can be applied to services rendered in a hospital outpatient setting as opposed to a community or a freestanding setting. And then finally, community appropriate care, which is our term for thinking about moving care that can be safely and effectively delivered in community hospitals out of teaching hospitals or academic medical centers and back into the community, and ways that we can go about doing that. I'm just going to keep pushing forward here because this is kind of all just context for the next part of the conversation. On an efficient and high-quality healthcare delivery system, number 7, you can see a recommendation around unnecessary hospital and other institutional care use, so both acute care hospitals and potentially skilled nursing facilities, and a number of different recommendations. We had some interesting findings in the cost trends report around substance use disorder and the continued impact of the opioid epidemic on our healthcare system, tremendous increases in opioid-related emergency department visits, and so had a recommendation to continue to monitor and enhance our care delivery system to meet that growing need. And then finally, in the cost trends report, we did an analysis that looked at rates of delivering of procedures and services that are recognized to be, in many cases, non-clinically appropriate. So think of the Choosing Wisely campaign, imaging, different types of tests, and we looked at that and tracked that against a number of provider organizations to see at what rate they are actually ordering those types of procedures. And so an insight both in terms of a lot of variability within the state, but also a potential quality improvement opportunity for the Commonwealth. On aligning incentives, 2 sub-recommendations here. One is around increasing the reach of our alternative payment methodologies, and you can see some sub-targets there. Would note, of course, we do expect some great progress in the next year with the Mass Health program. And the second recommendation here is not only extending the reach of those APMs, but making sure that they are as effective as possible. And so here, a recommendation around alignment and improvement of alternative payment methodologies, improving our quality measurement, including behavioral health, and reducing disparities that may occur in what different global budgets different providers receive. And then finally, on advancing aligned and effective incentives, these are the kind of quote-unquote demand side, and thinking about how consumers and employers can help consumers make choices around well-designed health plans, value-based health insurance, shopping on the connector, engaging all aspects of the community in this. And then finally, lucky number 13, data measurement, and a number of sub-recommendations here. So I blew through those relatively quickly because this is just kind of a foundational element for the next conversation. And so I'm going to keep moving and then stop and open this up. So this next slide summarizes all of those. And so maybe keep on your track here, slide number 20, when we get to the conversation point, because the way we talked about this with our board at the last meeting is you can see little asterisks next to some of these. These were areas where our board, at least initially had said, this seems like a good area for the HPC to continue to lean in on. You're not bound by the asterisks, so I'm going to ask you in a minute here to think about, of these different 13 categories, which ones are most appropriate for the HPC to push forward. Adding to that list of recommendations, because obviously that is a non-extensive list, I wanted to show you this slide on slide 21, which is something that we did a couple of years ago, actually, that looked at and tried to estimate total, what we call, quote unquote, wasteful spending in Massachusetts, which is to say, and I think it may not be in your packets here, but if it is on the slides, in the visual slides, we recreated an analysis that's been done by many different academics, including the one sitting to my left, in terms of trying to quantify the amount of spending that occurs in our healthcare system that is not providing value to patients. And we recreated some of those national estimates on a statewide basis and found anywhere between $12 to $22 billion annual in potential kind of quote-unquote wasteful spending. And you can see the different categories up on the screen. It ranges from things from over-treatment to failure of coordination to also things like just the administrative complexity of our healthcare system. I always put this slide up, and I think people get anxious that I think we were proposing that we could take $12 or $22 billion out of our healthcare system tomorrow, and that there'll be no consequences attached to that. Of course, that is not what I would propose. This is really a reflection of what an ideal, most efficient healthcare system could be, and not necessarily a reflection of where we are today. That being said, I do think it provides a window of opportunity to say there are places where we can go in order to make our healthcare system more efficient that don't mean compromising the values in terms of patient care. So this is the big macro number. And then what we did in the slide that you have in front of you, which is kind of estimated opportunities, is the more micro and targeted, which is to say, okay, let's actually be really tactful here, and think about in some of these different categories, what could the potential savings be if we were able to actually make some progress? And again, this is a non-exhaustive list of all the different areas you can go, and I won't read through them, but you can see here if we were able to make some progress on readmissions or avoidable EDUs, what that could mean in terms of overall savings to our healthcare system. And we use this at our benchmark hearing, again, to try to provide a starting point for a conversation, hopefully with many of you and with others around. Let's think about marrying the recommendations, marrying these cost estimates and saying, let's try to identify some places where we could all work together and make some tremendous progress that everyone would be able to benefit and be on board with. And so, again, non-exhaustive, but something for us to react to. Finally, I talked through this at the last advisory council meeting, but we've now put together a nice fancy slide with some graphics. But really, this is just a reflection of what are the different roles the Health Policy Commission can play in pushing some of these ideas or priorities forward, from our research and reporting to bringing people together and convening, to being a partner in terms of an investment partner or a partner with an individual organization, to also, in some cases, being a watchdog on behalf of consumers and calling out and spotlighting dysfunction that may occur in the system. So that was a lot to absorb, and I know some of you around the room have kind of heard parts of this presentation before, so I wanted to kind of move through this quickly. But at this point, I'm going to kind of hopefully try to stop talking, and you can see some of the different discussion questions here. But looking at those two lists, either the cost trends report recommendations or those lists of kind of modeled savings, or others, I think this is the opportunity that I really want to hear from this advisory council. When you look at that list and you see those different opportunities, and you think about the levers that the HPC has, what is your advice and counsel for me that I can bring to my board in terms of where we should be really thinking and focusing our efforts in the next 2 years? And so that is the next whole part of this meeting really is to hear from you, and I'm happy, of course, to answer questions around that. Before we kind of open it up and start thinking about what you might want to say here, I'm just going to ask Commissioner Berwick, since I do have a member of the board here, if he has any other thoughts he'd like to add in terms of teeing up the conversation.
Well, I'm
No, I'm mainly looking forward to your thoughts. I've got some very specific questions I'd like to ask during the flow of it. Maybe one tee-up question is, as David said, part of my research background was looking at waste in American healthcare, and the numbers that he put up on page 21, that model speculates on the levels of non-value-added activity in care. We don't want to ration care, we don't want to take care away from people that it helps them, but if we're spending money on things that don't help people, that would be a place to go, both improving quality and reducing costs. The 5 categories David put up there are what I explored with the Rand Corporation on a national scale. We ended up with an estimate that 34% of the $3 trillion America spends on healthcare it just doesn't buy anything. It's those categories. And you left one off, which is fraud and abuse. You might want to have a little conversation with that in Massachusetts. Is that a problem or not? I guess for you as leaders, my question in part of the conversation, do you believe that? Is this not credible in terms of your experience as leaders in healthcare in the Commonwealth? Or do you think the problem is not that the waste isn't there, is that the waste is there, but it's really hard to extract it from the system? I appreciate your feedback on that. And I've got one more specific question for you.
The doctor has asked a question. Who's going to jump in?
I was just going to ask a clarifying question on the data, and in terms of the Massachusetts data. So I'm assuming that the drill down to come up with the dollars in the category is very reliable in those different kind of areas. Yes.
In this one right here.
Yeah.
Yep. So I didn't include all of the methodological breakdown on these, and we can get that to you. But the low savings in many of these different cases was kind of what we estimated would be an achievable movement in the right direction. The high savings are something that would be a more aggressive turn, and I can talk through what some of those assumptions were. I would say, the way I've described this savings methodology is not back of the envelope, but not a multivariate regression analysis over multiple years. So I think it's important to kind of think about these in terms of the scale and scope, and I wouldn't hang my hat on 43 million versus 42 million, but I will stand behind the numbers.
Thank you.
Oh, go ahead.
How do you reconcile these figures with the chart? I'm trying to understand healthcare expenditures about so the chart that you had previously is not is it about 22 out of 55 billion?
So this is 21 to 39% is what we estimated in terms of the total savings off of a $57 billion base. I think the important difference here is where we're talking about, potentially reducing hospital readmissions. We're talking about percentages of reducing hospital readmissions. This is talking about if there were no hospital readmissions. So these are, what we would call more achievable, and you can dial up or dial down what you think is achievable. And certainly some may say that even on the high savings, we set ourselves too low or too high. But the major number is kind of if we're able to get rid of every one of those questions.
I just had a question about the data measurement section.
Yep.
How much discussion, if there has been an outright data interoperability, and the ability to use data across systems in the city? Is that part of the discussion? Because I think that's probably the biggest issue is disparate data systems that we need to talk to each other.
Yeah, so that was not one of our recommendations this year. I think it was actually one of our recommendations in the last year's cost trends report, and continues to be a top priority. We definitely hear from providers especially that they need to be able to have good, accurate data in order to drive their care coordination or quality improvement. I would note the Mass Highway, which is our platform for interoperable data exchange, has made a number of improvements in the last 12 months, but just because it's not included here does not mean it's not a priority.
Laura, could you expand a little bit? What's it like out there with respect to interoperability right now? What's your experience?
It's kind of a mess, actually. I serve on the Value and Healthcare Committee for the World Economic Forum, and this is an issue that has been raised globally about the ability to use data and be able to, the systems to talk to each other. One of the issues has been the EMR vendors, because we're not able to connect them, and I believe this is being addressed in Washington on that. But also all the data, for example, that my company, their systems create, how do you make sure that that's all interoperable? I think we're not there yet, and I feel like it's an opportunity for a state like Massachusetts to really address this issue and serve kind of as a, for lack of a better term, a beacon for the rest of the country, because there are parts of the country where there's no data interoperability at all. And so that's why.
All right, Diane, and then I'll get back to
So, Dave, as far as your question in regard to this list, I'm very, very happy to see all these items on this list, because I think that they are exactly very tangible. I think they're the right list. I think it's probably not exhaustive. There are other things as well. But as far as the key levers that we can really pull to significantly make a difference here, absolutely one, absolutely. And I think many of us, I know, that have been involved with risk contracts or with the Pioneer model and then soon to be the Medicaid ACO. These are exactly the things that we're pushing on, and we have seen significant savings already over the past couple of years in our area on these. And one of the most interesting things that has popped up in all of our data is that one of the biggest spends for, you think it's admissions, you think it's a whole variety of things, but one of the biggest spends that we really have an opportunity to change is post-acute and home care.
Thank you, and I, certainly many of these different categories, the risk contracts are incentivizing, provider systems to make progress on many of these different areas, and for hospitals that are part of our CHART program, our investment program, our primary aims are reducing readmissions, reducing ED revisits, reducing avoidable admissions. It's all of those different things. The underlying data here, we did note we do have a higher rate of discharge to institutional settings, skilled nursing facilities, or rehab facilities than the United States. We have in past cost trends reports identified a lot of variability even among hospitals in Massachusetts in terms of where patients go for the same type of procedure. So maybe just, I know we have representatives of home care and Mass Senior Care here. Maybe just spend a moment on the post-acute care side of this, because I think it's, I had a conversation with Meg the other day in terms of what is driving some of that variation that we see, and what role could the state or the HPC play in terms of helping to identify some of those best practices and have them be more widely adopted. I don't know, Meg, if you want to.
I think one of the conversations goes back to some prior comments, and that is around access to data. So being able to look at claims data, being able to measure, and also interoperability, because, so for example, as you're trying to do things with SCOs and others, there's a wall between communication. One, when was someone hospitalized, as simple as that, to how do you communicate actionable information in a timely way, so that when you're in the home and you're trying to communicate, how do you get that intervention before that hospitalization occurs. So I think communication and data is a huge barrier for us right now.
Tara?
So I appreciate this topic being brought up, and it's one that we have commented on many times, a willingness to really have us look under the hood, if you will, of post-acute care, and particularly skilled nursing facility care, because I think there has been, I don't know if it's criticism, but of an overutilization of SNF care. But remember, we expanded SNF care at the request of hospitals, quite honestly, that wanted to maximize the DRG and move patients along to a lower care setting. And I think that in some ways, there's opportunity to continue to support skilled nursing facility care, as well as pass them off to home health as quickly as possible. And we've made a lot of progress in reducing length of stay. Dr. Dunlop once spoke at one of these meetings about misalignment of incentives. Hospitals are paid by DRG, we're paid based on daily length of stay. So it's not often in a fee-for-service market in a SNF's interest to discharge as quickly. Of course, there's not fraud, you wouldn't keep people longer than they need to be, but there's misalignment of incentives in the payment system right now. Skilled nursing facilities are absolutely willing to partner with hospitals to work and see how we can control that length of stay. But those partnerships are few and far between at this point. We're committed to readmissions and working with SNFs, working with hospitals. And then what I would add to this discussion as you think about post-acute care are two things. One is we could be certainly an avoidable hospital admission with low acuity diagnoses. The second is that you consider our aging demographics. And the third is workforce. We are finding tremendous challenges when we go to discharge to the community. We have agencies that are saying we can't take your patients right now because of workforce challenges. So I appreciate the topic always being part of HPC recommendation, but I think there's a lot of texture to that and a lot more discussion that should be had.
Yeah, and I think the certainly my perspective is more just around kind of right sizing and figuring out how to make those connections work, and certainly a skilled nursing facility can be the cost effective setting as compared to other settings. So absolutely. I just want to press you on one point that you made, which is just around the partnership with hospitals or health systems and being able to think about a lot more aligned incentives and potentially seeing that as part of the future. You said you didn't see it as much as you hope. I guess what are you seeing as some of the barriers to
So
that?
I think that skilled nursing facilities, and we have repeatedly testified on this and saw ourselves as part of a solution in Chapter 224, would like to be able to enter risk-bearing contracts with hospitals. So if you look at the Pioneer savings, that would, and if you look more closely at it, it's absolutely the result of a reduction in length of stay or a skip of the skilled nursing facility. And what that means is the money goes to someplace else as opposed to reinvesting in the post-acute system. So those are areas where we would like to further explore. End of life, there's great opportunity for us to collaborate on end of life. Medication reconciliation, since ours is all an inclusive rate, we don't bill separately for drugs. So when a patient comes out of the hospital with, those drugs are very, very costly, and we, again, pay for that as an all-inclusive $500 rate on average. So there's a lot of low-hanging fruit. It's just a matter of finding willing partners to engage.
In our work on ACOs in the state and in the 1115 waiver, are we beginning to embrace post-acute, or has that been left out of the picture?
Well, the 1115 waiver, as I see it, and MassHealth can speak differently, but that really is that under 65 population. So it's Medicare is where we see a lot of the post-acute. That's the funding source. Over on the Medicaid side, I would jump to another concern, which is the substance use disorder population. So we are increasingly being asked by hospitals to take care of medically necessary skilled need who also happen to have an active substance use disorder behavioral health. So we see hopefully opportunities, fingers crossed, to work with the behavioral health community partners to make sure that we can bring in services to the skilled nursing facility and most importantly, discharge them to a safe location. So we're hopeful, I guess, but it's a different population.
Lynn?
Yeah, I wanted to, the conversation that was just had, I think was very relevant to the point I wanted to make, going back to Dr. Berwick's question about slide 21, which showed that spectrum of areas to look at a really high level. When I sit in on so many of our meetings, we have so many forums in MHA, you can probably imagine. Yesterday we had meetings of our large physician practice groups, we had our CMOs, when we meet with our behavioral health folks, when we meet with everyone, the one issue that always comes up in the conversation is failures of care coordination. And also, there's a variety of issues that I think arise in that. I mean, we think this is so important. We had our post-acutes that all met together, our LTACs and rehabs and our acute care hospitals, and we have a work group for everything on earth. And we created a new one that's going to be chaired by Lou Wolfett, who's Senior Life, but it's a continuum of care council. It's having its first meeting soon. And that group is comprised of representatives from within the entire hospital spectrum and the post-acute spectrum. So we have invited to our group, home health, long-term, every group, every perspective is there, because that is where the opportunities lie, I think. The failure of care coordination, I think, actually leads a lot to the overtreatment issue that's on there, on that, you know. And when I listen to the examples people raise, one is totally the health information technology, you know, talking past each other. I know we're doing some things with the Mass Highway. I think the Mass Highway lost some of its oomph and traction in terms of really being the resource it could over a few years, and I think they're trying to revitalize that, but I think we lost a lot of ground, and that could be an absolute priority, because so much of what's done is because you know, there's just the redundancy of things that people don't know. They don't know what they don't know, and so they do it. The failures of care coordination with the whole behavioral health spectrum, which was mentioned earlier. Big one, because that contributes so much to the comorbidity and conditions of people who have chronic disease, which is where all the money is. And the other one I would say is the post-acute world. Whenever I hear, particularly the docs talking about how they are trying to make care better and work within the contracts they have, the opportunities always come down to the post-acute. It comes, the word SNF is used more than any other word in the conversations, and it's just so hard to get that all working together. So I think those clinical things are so much more of an issue and an opportunity than pricing failures and administrative complexity and all of that. If we get the care right, and I think this is what, you know, Dr. Burrow would say, if you get the care right, everything else really follows and can be fixed more easily. And then just so I don't have to grab the mic again later, on the other priorities, one of the ones I think should be a really high priority quickly is the establishing a way to measure total medical expense across all providers. Because whatever you do in all these areas, you want to look at baseline and you want to look at before and after. It would be so much more effective to be looking at it as TME instead of pricing the way you do now. And if we could get that done, and I think we're close, then that could become a framework for measurement for everything else that we decide to accomplish.
Ron, I'll get to you in just one second. I just want to follow up. One, on the last point you made, we are making progress on that point, and HPC and SHIA have been engaged in some methodological work around having TME measures for organizations besides just the PCP groups, which is currently what we have. You know, you mentioned some of the post-acute care and the care coordination and kind of some of the getting the clinical care right, Lynn. And I guess my question to you is, I of course agree. When we think about the Health Policy Commission, what do you think our role is in terms of HPC, and you know as well, in helping that conversation or to be able to make progress? Or are those areas where, you know, that's not really our role to kind of lean in? And you mentioned that there are already, you know, private actions and convenings happening. I guess I'm trying to reflect on for the HPC's work, how do you see us supporting progress in some of those areas?
Probably, and the way we're starting our new Continuing Care Council meeting is we're having everyone weigh in on what they see as the three biggest barriers to coordination of care. I think if we identify from everyone's perspective what they see are the biggest barriers, and then other than those that we can't change because they're federal, if we could prioritize and begin to work on those. And some of them have to do with just state regs and things like that. Some of them have to do with information issues. People know what to do. They know what they want to do, what they're trying to do. They just keep running into barriers. And I'd start there, and then ideas probably that are more forward-thinking might emerge from that. That'd be one approach.
That's great. Ron, and then I'll come back. So.
Basically, when it goes to post-acute care, as a provider, it's a black hole. So there's a gap between when that patient leaves the hospital, when you saw them, and the time that they emerge from the post-acute care. And you don't assume care until that point. Now, in the few cases, for instance, at Braintree Hospital, we have some hospitalists that work both with us at South Shore and at Rankin, they'll give me a call, and I can give them a directive on what to do with the patient, and prevent that patient from being readmitted. So the post-acute care system was the stepchild of the information technology highway and the whole implementation, that they should have been linked to the hospital. So the only way it really works is large systems just vertically integrate. They buy the SNF system, and it's part of it. But in Michigan, some of my friends tell me that the TRI system went to the SNFs and worked out this. They explained to them that they would make up in volume the days they lost in length of stay, so that in fact they worked on an integrated system that kept the SNFs alive. So the biggest problem we have with all of this is that you have to survive the current payment system while you transition to the next. And so, some people say I have one foot in both boats and so forth, but you really have to keep your doors open while you plan for the next. And I don't see the planning moving forward as quickly as we think it is. And so that inappropriate utilization, even within provider groups, you don't know who's ordering so many ultrasounds and RF. There's like a 400% variation in my own practice. So once we were forced to look at that by an accreditation agency, now you get to normalize that and say who's under ordering, who's over ordering. So a lot of this is lack of communication. So the sooner you can see that patient when they leave the hospital, the less likely it is that they'll be
I think John, and then I'll come back to you.
Yeah, this is back to your question to Lynn about what the HPC could do in terms of the care coordination. I'm just looking at this list of chart projects, and there are probably 5 or 6 that other hospitals could really learn from. And it's not, some of it is rocket science, but a lot of it is not rocket science. So there are a lot of things I think that can be shared beyond the hospitals that received the initial track grant that worked, and also some maybe that didn't. I think that's an easy thing that could be done fairly low resource without funding new grants, because I know that that's always.
John, what are 2 to catch you off?
Well, general, simplified and accelerated, getting to Laurel's point, and others, simplified and accelerated the ability to electronically exchange health information with other providers, including direct messaging solution. It's something simple, and I've got to think that they address the HIPAA issues and all those kind of issues that others again can learn from.
John, you are so on message. Thank you for that. You teed up actually something that is, I will say now, is going to be an ask of this advisory council after this meeting. To date, John, our focus specifically with the hospital investment program, our CHART program, has been a lot of convenings among the CHART hospitals themselves, and we do a lot of regional convenings where we bring the hospitals together to share lessons learned, barriers, the care teams. So many of them focused on breaking down these communication silos that can occur within an institution, between departments within an institution, out into the community and beyond. And I think one of my priorities, for the year, and I hope to continue to have the support of the board on this, is making that a wider circle in terms of being able to share the learnings and disseminating, and not necessarily, again, HPC going out and telling other hospitals how to do this and how to make it effective, but making the connections between the different groups so that they can learn from each other. And I think what we're calling our learning and dissemination strategy when it comes to our investment programs, such that we're getting much more impact than just the grant that we're funding, but being able to say, okay, beyond just that grant-funded experience, how can we make that something that has a broader impact? And so the ask that you'll be getting later this week, maybe even as early as today, is we are actually going to send you guys a survey when it comes to helping us shape what we're calling our L&D, or learning and dissemination strategy. So you teed me up a little bit there, John. That was great. Thank you. David, I know that you had your hand up.
Thank you. I was just going to kind of like a microcosm and pick up on the point Dr. Dunlap made. In the behavioral health world and psychiatry, which I spent my career in, our big problem really is that black hole. When we discharge a patient, often they have to wait weeks for a follow-up visit, and they have to stay on their medicine or they're going to come back in the hospital. So if we had a good system that people could flow through and get care promptly and show up and stay on their meds, we'd end a lot of recidivism in behavioral health. Now, the only thing about that is it's not a lot of huge savings. It's not gonna, it's not 52 billion or whatever. It's minor in terms of the deliverable, but I'd say those first 3 points there, overtreatment, failures of care delivery, failures of care coordinating, are all applicable to behavioral health. And I don't know if it's within the purview of Health Policy Commission, but workforce. If the Health Policy Commission could look at workforce and how that could be bolstered, both inpatient. We have empty beds in Massachusetts because we don't have the psychiatrists to staff the units, which of course leads to ED boarding. That's happening now. As well, the shortage in the outpatient world, where people will wait for weeks for an appointment. So I think that it's kind of a microcosm of the bigger problems.
Yeah, thank you. I agree. They do. These same concepts translate to many different types of patient populations. I'll reflect with you, David. When I go and talk to different organizations and talk about the work of the HPC, the issues of workforce come up a lot in terms of telling me, David, it sounds like you have a great plan, but we're having difficulty filling some of these key positions, especially in the behavioral health space, but across a whole range of different positions, crucial to kind of meeting that need for the future. And where labor, of course, and workforce is such a huge part of the cost of our healthcare system. I would say it has not been something that has been a priority of the HPC over the last couple of years in terms of looking into that. And I think that's really a reflection of Chapter 224, which did not identify that as one of our key initial priorities. But interested in hearing from others on this point as you give your comments in terms of should this be something where we lean into a little bit more in our next set of years here as being a key issue to meet some of our shared goals. Oh yeah, sure.
You gave me my lead. I was wondering, I agree totally about communication, by the way, with everybody on that, but on workforce, right now, I'm working with a couple of our members on a question of how they're gonna close their panels because they've got waiting lists of several thousand people. And I think taking a look, when I'm looking even at this chart, I don't think enough focus has been on, well, what are the costs and what is the payment structure for the alternatives out there in the community, behavioral health being one, community care, and I'll take that right out through farmers markets and all the other good stuff, and whether that's really healthcare and so on. But there are the things that will create the reduction of emergency room use and all the rest of that rely on a combination of the kind of workers who will take that burden off. And I certainly would like to see some way of taking a better look at that, whether it's salaries in certain professions, but almost how that alternative system ought to work in order to make things bigger, work better on the higher price sort of established healthcare side of things.
I do. I think I want to commit a HIPAA violation here. This conversation about coordination is fascinating to me, and a lot of you are focusing on technology, and I'm just thinking about culture here. Here's the HIPAA violation. So there's a close member of my family who's in an LTAC right now, about to go home. And yesterday, the care coordinator called me and said, "Look, here's what's going to happen. We're going to give your relative a package of pills and our prescriptions, and he'll fill that prescription, then he'll go home. Then he'll call his primary doctor, make an appointment, go in, and the primary doctor will then prescribe the medicines that he wants the patient on." I said, "I got an idea. Why don't you call the primary doctor first? And your doctor can work it out so there won't be a switch of meds. I'm sure meds will be thrown out. I'm sure the patient will be at risk because he'll get confused. Why not? You could say a computer is missing, but is there something else going here in the way we think about care that needs to be addressed?" But I don't know what the HPC can do about that, but I'm curious to know what you think about that.
So I want to say that of the 4 priority areas, promoting an efficient, high quality care delivery system, is a set of new competencies for the HPC. And not completely new. I mean, I think you've been in the chart space, and I think if you really think about the performance improvement plan, the PIP space you're going to be in, some of that, probably the right good plan is going to intersect with that. But I think for the most part, you haven't been the Institute of Quality Improvement, and I can imagine the providers around here don't want, the HPC also to be the regulator, of just pure shame and blame, and probably rather see it more on the claim side. But I do think you need some staff that can come in, I'm not saying you don't have it at all, but I mean, perhaps greater numbers for the convening, partnering side, so that if you want to see, for example, as highlighted in a report a few years ago, with hip replacement, that more of our providers emulate the Baptists in terms of, quality and less use of overall resources, there's got to be conversations that ultimately follow-up activity that get us there. Now, as Lynn says, some of that might come from the private sector on its own, in which case that HPC probably doesn't need to overly assert itself. But there's lots of areas on that list where you guys highlight the problem, and there really is an insufficient activity. And I think there you really, just need to stick your nose into it and not be fearful of that. So that's my point.
Thanks, Paul. And this is something we think a lot about. I think at the same time, we're not IHI, and we're a government organization, and I think our experience in some of the chart settings has been it is much more fruitful when we can help facilitate a conversation among providers than for the HPC or our staff to try to weigh in and say, we know how to do discharge planning. And that's just, in terms of what our role is.
I guess if your data keeps showing up year in year that something is a problem, but we don't seem to be making any progress on it, I would say you'd be derelict in your duty not to, if all you do is point out, gee, that number still looks bad, and not go beyond that. And what that exactly is, I don't know, but I want you guys to feel liberated to say you can move a little bit more into that space.
Dereliction of duty. All right. Wow. Diane, have you jumped in here?
Yeah. So I think Dr. has taken an extremely important point, because one of the first things I jotted down here coming in was, you guys have done some fabulous work and research, and if you look at the list of all of the recommendations you have, it's basically pointing us to, if they could all be enacted in a very bold way across the Commonwealth, we really would achieve the cost goals and really make a significant difference. So I guess it's how can HPC have a stronger enactor side, or to help everybody on the execution side? Because then I worry that, look at even just the chart grant, the chart experience. We've had some fabulous results in all these chart proposals, but how is it going to be sustainable when the grants go away? I mean, I'm sad to think that we may not be able to continue this terrific work we've had with managing extremely vulnerable, socially complex patients. But if the money's not there, how do we do it?
And I think, as you'll see in our recommendations, in many cases, our recommendations will read like, the Commonwealth should reduce readmissions by 20%. We are not going that next level deeper in terms of saying, okay, what would this specific, what is the roadmap to get us there? And I don't think that we can do that for all of these things, but there may be areas, again, in coordination with a broader group, not just the HPC, but the community, to say, okay, let's pick a couple of these and really be able to make some progress. I'm going to try to get to some people who haven't had a chance to talk yet, so Eric?
Yeah, and David, this could wait a couple of minutes. I just wanted to get in the queue around prescription drugs and pharmaceutical spending. I don't want to disrupt the flow around care delivery and.
Let's just put a pin in that. We'll get back to pharma. Steve?
So, the initial question asked was are the numbers right? And I think the numbers are extraordinarily low. I think there's a lot more savings that can be had. That was your first question. And the question the HPC asked was, what would inhibit your success? And I think it is that you aren't a regulatory body. I think that makes it awfully difficult for you. But the one thing 224 called for, and every one of these things is based off of, is moving towards APMs. And it's finally, that's helped us do great right now to push that market, and that will help bring others along. But when you look at readmissions, when you look at ED use, when you look at right down the list, post-acute, when you look at primary care providers, that's all based on a fee-for-service chassis. Until that changes, there is zero incentive for us to make this change. And so the chart program is a perfect example because you paid for care coordination, but you paid for it as a bridge to when the market actually paid for care coordination. And the market hasn't worked as fast as chart has, and it hasn't caught up. And so as soon as they catch up, it would be in our best interest to call Tara and to work with her. And we have. Our board members are going to meet with her board members. We're going to talk about some care coordination that we can do to make post-acute work better. But as long as we're being paid fee for service and then she's being paid fee for service, there's zero reason why we should connect on that patient because it's adversarial by its very nature. And I think that's a problem. So I thought that was missed 2 board meetings ago where there was a discussion about readmissions. And it was fairly, it was a fairly harsh discussion around hospitals. And, you know, obviously that is the board's discussion and they have every right to their opinion and respect that. I think the challenge or the missing piece of that is that when a patient leaves the walls of the hospital, we can't drive them to Walgreens to make sure they're compliant with their medication. We can't follow them to the post-acute care to make sure that they're getting the right care. Yet we're penalized with the readmission if they come back to us. As soon as we move away from the fee-for-service world and into an APM type world, we care about that patient all the way around. And if you look at some of the stuff out in the Lowell General Hospital, I talked about this in your forum on Monday, they will literally tackle the patient as they leave the door to make sure that they're getting the right care, to make sure they don't show up, because they've changed their risk models. And they're coordinating their care with the center. And some of our other community hospitals are doing a great job. So I think the first thing that you do is a move away from fee-for-service. Every bit of energy that you have in terms of pushing that, and then everything else will build upon that. And I think in terms of driving care to community appropriate settings, I think you can do that because one of the things you do have is the ability to look at hospitals as they're doing affiliations and mergers and they're trying to find the right strategic partnership. And you have highlighted some of the community hospitals and the academic medical centers that through the hub and spoke model have done a really, really good job of that. And so I think the more you do that, the more folks that come to you to find their right strategic ally moving forward so they can stay open in perpetuity, when you look at that as how you're going to judge them and it's based on moving community appropriate care, you're going to see that savings double and triple. I think when we looked at this a couple years ago, and David, you were a part of it with Professor Cutler, it was $18 billion of the $60 billion commercial spend that we identified as waste. So this is just scratching the surface of what we could do if you could move everybody in the right direction.
Steve, just a couple of points of agreement. I think, to me, I think about the alternative payment methodologies as being an incredibly powerful enabler of all of these other changes that we want, and creating the financial incentives in the business model to be able to do the right thing on behalf of patients. And when I think about the CHART program and the question that was raised around sustainability, you're absolutely right. We've always thought that the move towards these contracts will be that sustainability model. It hasn't moved as quickly as we would have hoped. And I think, again, you know, as I highlighted this slide again, in terms of our recommendations, I think the way we think about this is not just around extending it more, but making sure that the contracts that are there are working as well as they can and align the incentives. And would highlight in one area where the executive office is convening some people to talk around is having some more alignment on quality measurement with regard to APM, so that not all providers have 14 different contracts with 100 different measures that they're being targeted against. Let's try to think about how we can be more focused in how these contracts work. So absolutely agree, and this was one of the asterisks, is one that my board talked about. This doesn't make that care coordination and communication happen on its own, but it can be an enabler for breaking down some of those silos. Christy, and then I'll move back around.
And just, Steve, I'm glad I didn't speak before your comments. Absolutely correct. And I think this is about looking at what the continuum of care is. We have all of the right pieces, parts of a healthcare system. Care coordination exposes probably the greatest weaknesses in them. And Dr. Berwick, I'll take your HIPAA violation scenario and raise you a person with severe mental illness in that scenario. And talk about including behavioral health and severe mental illness, which is not an insignificant amount of the spend, and how the system can do better. And it's about the relationship between primary care, acute care,
an outpatient continuum of care that in the Medicaid ACO redesign, we have the behavioral health community partners that hold promise of being such a critical foundational component of keeping those other parts of the system for the severe and all persons with mental health conditions safe and receiving care in the best possible place.
And this is such a crucial conversation. I just want to understand something, and excuse my ignorance. Is the current ACO model that we're working with in the Commonwealth models, because we've got Medicare and commercial and so on, are they sufficiently aggressive about the coordination and combination of financing you're talking about, or are you actually calling to our attention the possible need for yet another model beyond
They're not
the
enough
ACO?
of them.
They're not enough of them?
They're just not enough of them. Just quickly to Christine and Steve's point, I think that I was gonna say the answer to your provocative question. The answer to that is because in that scenario described, they are not under a risk-based alternative payment model that makes that provider accountable for the patient for the whole. Steve described it exactly. And when they are, all of these things get done because it's in their best interest. You know, people do what they're paid to do and they're incentivized by how they're paid. That's how the system got so dysfunctional. And the way to make it functional again is to have these alternative payment models that really reward you for doing the right thing through the continuum and whack you significantly financially if you don't do it. And every one of these clinical things and handoffs and post-acute and acute are all facilitated. So when I talk about the physicians that we met with that were talking about they were talking about them in the context of risk-based models where they're trying to make it work, and yet there's not enough risk-based models for everybody to do it the same way because it's a perverse incentive for its fee-for-service. And you've got to get in line. And so moving on that, you know, if we had, I was on the first payment commission that recommended years ago that we move away from fee-for-service, and we said voluntarily, you know, as quickly as we can, facilitate it. I often think now that I'm leaving, what if we had actually said that it wasn't voluntary, but it was going to be the law of the land over time, just as we've done the TME goal? If we had said that back then, as much as people were freaked out about the ability to do it, now they're upset that it's not moving fast enough and that it's not for all payers. So it's not enough for Mass Health just to do it and for Medicare to do it and Blue Cross and some of the payers to push it where they can, but all needs to be that way.
Yeah.
I think Steve described it very well.
And Lynn, just to reflect, I think Ron mentioned this earlier, we've been using the canoe metaphor. I think we probably used that metaphor at our very first HPC Advisory Council meeting 4 years ago. It still feels like there's a lot of progress left to be made on this point. I'm gonna go around here, Ron, and then Meg.
Just to answer your question, the problem with, two problems with ACOs. One is that this is such a highly competitive area. So for instance, on the South Shore, we have something like 5 ACOs working. When you do a narrow network, you have to have network adequacy. Like Noah had 2 of everybody in the building. If you only had 1, he was in trouble. So here we have systems that are competing, and with the acquisition of practices, sometimes one group gets all the neurologists, one group gets all the cardiologists. So we have our patients bouncing between systems. So we actually have programmed leakage in these systems. So the only way to achieve that ACO goal would be to establish a community standard for quality, community database, and if everybody would work for CHF, or whatever you want to name, together, then you would have the ability to mine that data and see who's doing well. The other problem was that you're measured against yourself. So the Mount Auburn folks were doing a good job already. They did the Pioneer ACO and said, wait a minute, we're being measured against our progress last year. We didn't have a big enough delta. We're not measuring against the people who are not doing this well in this community. So that's a huge issue. So I made a presentation last week to the entire South Shore from the Cape up about this competitive issue in our area, that perhaps people out of network in the community could be cheaper than the person in the academic medical center that you sent to. But what's happening is if you don't have X in your system, you're putting the patient in a car to Boston. when you may have an effective provider locally. So the issue would be, what can you do with these deductibles? If the person in the community is a quality provider with equivalent cost, the patient shouldn't be hit with a high deductible on that if it's revenue neutral to the system or even an improvement.
Ron, wouldn't the logic of your comment, thank you, be for a single ACO for a community that there should not be multiple?
That's the issue I brought up. You know, in California, they've done virtual ACOs. So my argument was that we should have, they all talk about a community network. And I was at a meeting with South Shore. They said, oh, our community health system. I said, you only have 25% of the providers. You can't talk about the community health center unless you get 90 or 95% of the providers on base. And you won't survive unless they all continue to use your hospital. So there are ways, I think, that the entire community could work on programs. We have, the only example I have of this is that we have a cath lab where, because the state required us to do a research study to prove that we were competent, we now have a registry that includes all the practices that use the lab. It is in our best interest to have good quality metrics and low complications for all of us. So now but that requires the hospital to pay 1.5 FTE for the data management and the state to make sure that we, comply to this registry. So we've now learned to swim in the same direction. I don't see why we couldn't do that broadly across the community, across networks, do the same thing for other areas.
Ron, I would add one reflection that I've had where I've been encouraged in some communities, in many communities across the Commonwealth, where different provider organizations and community organizations have really come together and worked together on the opioid and substance use disorder issues, and how that's created, I think, a platform for coordinated, cross-provider system action. Not everywhere, but there are these incredible places in the Commonwealth where that has. And so how can you say, okay, we have this incredibly complex population, let's think about broadening how we view that and how we can all share in providing right treatment and communication from law enforcement to the schools, to the judicial system, all the way through. So that's just one reflection that I've seen in the Commonwealth. Meg, and then I'm going to come back around.
I just wanted to put a name to it and say social determinants of health. So how do we truly integrate that as part of care coordination when it's not considered medical? And hospitals like Diane Anderson, who's done a wonderful job of looking at that through the CHART program, has seen success. Multiple grant-based funded programs that different home care agencies have done have shown results. And at the end of the day, the hospitals say, understandably, we can't afford to pay for it, so they go away. So you see the success and the result of that diabetic patient who doesn't have enough money at the end of the month, and so they end up in the emergency room because they don't eat well, or they can't get to the doctor, or someone can't afford medication. So, how do we start to look and measure those kind of outcomes? Because I remember being in home health and saying, you start here in the hospital, a SNF or home health, and then you've got the valley and they're doing well, discharged, met all goals, and then it starts up again, right? So then they start back up because then they get sicker and so on. So how do we get a handle on social determinants and its impact on health and truly integrate it into the system?
Thank you for that. Cheryl?
I practiced as an NP in nursing homes for 10 years with a large group of nurse practitioners, and we did our very best to reach out to providers and spend as much time as humanly possible to try to figure that out on the days prior to discharge and getting the information where it needed to go. And I would have given my IT that I could have done a home visit after those discharges, but it was fee for service and it didn't work. And I left that model to go work on a CHART team in Greenfield, Massachusetts. So it's the same job. It's exactly the same job, except I get to go anywhere the person goes. I see them at home. I see them in a nursing home. I see them if they would let me go to the psych facility, I would see them at the psych facility, but they don't. And our aim is decrease ED utilization by 25% for folks who have a behavioral health diagnosis. It doesn't have to be primary, it can be secondary, or all inpatient for any reason. And in Western Mass, we have the Pioneer Valley Health Information Exchange. We have secure texting. I can reach out to any provider, and in a moment's notice, I would have given my ITs for this as well if I were in the SNF and we had it at the time. But we do pick them up in the ED and drive them to Walgreens to pick up their meds. We have 4 community health workers and a peer specialist who are literally meeting them in the ED. We are secure texting about what's going on. They follow them wherever they go. They pick them up at the time of discharge from whatever rehab they end up going to. If they will sign a release, and we get that in a meaningful way. So we're addressing the unnecessary hospital use and other institutional use because it's small. So we all know each other in Greenfield. We know the SNFs, we know the people, we sit with them every other week with all of those post-acute providers and the PNAs. And we talk about people instead of just a process. We actually talked about individuals who we all end up seeing. You know, it's a small community. So my concern is that this chart grant's ending, and the hospital is being paid for census, and I don't think this is gonna be funded. So it's very distressing to me and my team because these community health worker roles, 2 are at the LTAC, at the LTSS, right? So they're at our AAA, Life Path, and then 2 are at our psych provider who does crisis and who does respite. The peer specialist is from crisis, and they do such meaningful work and they have such good outcomes, and it's just not there yet, right? It's just not appreciated big picture. So the question about the immediacy, the communication, the care coordination has been a complete game changer for us. You know, my being able to reach out to any provider and say, what med did you actually mean? What dose did you actually mean? It's not coming across is incredibly helpful.
To give us a gift for 30 seconds, tell us about one patient appropriately disguised
Yesterday,
some story.
So yesterday, I went to someone's home. She's very rural, right? So she's living in Irving, up on Route 2. She was in the hospital with what they believe finally was serotonin syndrome. And she got her discharge instructions. I'm sitting with her while she's, looking at her bottles, which she couldn't fill. She couldn't get her meds the day of discharge. She was discharged really abruptly. Not that she wasn't ready. It was just quick. So I didn't know she left until the next morning. And she went right back and took that same SSRI that probably put her in there to begin with. So it should have been, they were going to try to wean her, try to decrease the dose. So it was literally calling a community health worker, can you take her to the pharmacy right this minute? Can the psychiatrist see her tomorrow? Like those kinds of in the moment, in the living room, what can we do today?
Thank you. All right, Cheryl.
I could not underscore exactly. Just, that's sort of think about the HPC. There are roles as convener, a role as doing the data management. I think we just need to, in some ways, with the sort of research and data, is monitor more interesting things. In some ways, I think the things that get measured and looked at are the things that get done, in addition to aligning the incentives around that. So I think we should have a conversation about what other kinds of things to do. And the other piece of this is just to add to the HIPAA violations that are happening around the room. Thinking about, I'm a hospitalist, I think about a patient that I had who didn't have a place to be discharged. As we think about the context of healthcare, housing insecurity, all of these issues, as we think about the continuum of care, that care is not just things that get done within healthcare institutions and post-acute care, et cetera. And we also need to think about, I think, the role of HPC as a convener, not just for healthcare organizations, but for this broader concept of how do you provide health. And how do we start to bring in other organizations and think about being more proactive, measuring and addressing the social determinants of health that have been brought in. So I think both of those roles are very powerful places that HPC can act.
Thank you. That was a great kind of tying together the last couple of comments and ways of the HPC, and certainly through the CHART program, through our research and through other things, our convening role. We had a big panel around social determinants of health at our last fostering hearings, and it's just such a huge part of this. And how do we make those connections between our what we traditionally think of the medical system and beyond?
So two comments and a question. First, I think on slide 22, the live slides, I think it's too low. I mean, if you're talking about 21 to 39% that was identified in the earlier study, this is barely a dent. And so that leads to one question and a comment, one comment and a question. I think I agree with Steve in terms of emphasizing APMs, particularly around APMs, right? Because most of the efforts that are done, at least on the commercial side, around the HMO population. But how do we figure out a model to make sure that folks that are in APMs, either ERISA ones or state-sponsored health plans, or state-rated, are actually almost sort of quasi-automatically pushed into APMs? Because that's really the trick at the end of the day, right? And then I guess the question I'll end with is, what did you consider but didn't make the list this slide here? Because at the end of the day, you went through presumably 30 or 40 ideas. And I'm kind of curious which ones that were maybe larger impact, maybe a little harder to achieve, did you decide not to put on the list?
Great question. The list actually began with the cost trends report. So every one of these was based off of a finding that we had in the report where we had said, okay, here's this trend, it's going in the wrong direction, it's stalled out. What if we were able to actually change that in a different way? So it wasn't actually something where we started with the big long 30 list. We started with kind of, all right, what does the data tell us in this report? But I think one of the things we're interested in, this was something we did basically within 6 weeks, 5 weeks, we put this list together. This was a conversation starter, and I think it has resonated with a lot of different audiences in terms of using this as a menu or a roadmap in terms of being able to help guide some of our efforts. And so, one, I think we will continue to add to this and to, maybe be more aggressive in what we think some of the targets could be. So, Eric, I cut you off before, so I'm going to come back around, and we're at time, but I just want to make sure people who hadn't had an opportunity to weigh in can just weigh in quickly. So, sorry about that, Eric.
Sorry. So we're thinking about this in the context of how do we make sure that the state, the healthcare, and the system meets the cost benchmark, seeing as how we've missed it for the last 2 years. And I think the big, one of the pieces that we really haven't been able to get our arms around as a system has been the issue of pharmaceutical spending. And I won't, in the interest of time, I won't go into a whole lot of detail, but I think what we've heard from various stakeholders over the last couple of years, whether it's health plans or hospitals, physician groups, employers, the state, et cetera, is that we need to do something about it. Now, there's some folks are going to say, well, it's more of a federal issue, and there's only so much things that the state can do, but there is, I think, a role for the Health Policy Commission, and I would, articulate 3 areas in which we think that the HPC could play a role to address this. One is certainly the hearings. For the last 2 years, the commission has had representatives from bio and pharma, the trade groups, but I think having the trade groups sit up there would be like having MAP and MHA and COVID and the community hospitals and et cetera. It doesn't provide for as rich a conversation and to answer the question of why are your prices going up, how did you set the prices, and the issues that we've addressed or have talked about. To that end, I think we would encourage the commission to update the statute. I know it's part of one of the recommendations, but I think if it's a concern, given where it's at in the conversation, it's time to update the statute to recognize that pharma and biotech not only have to be part of the hearings, but also should be submitting data much the same way that the health plans and hospitals and other providers are doing that. I think second, one issue that the commission has touched upon as part of the cost trends report, and we appreciate it, is this issue of prescription drug spending within the medical benefit. It's touched upon, but certainly an issue that needs a deeper analysis. And one area where the commission can probably dig into this is some sort of policy brief, much like what you did around price variation a year ago, to really, and out-of-network billing practices and those types of things, to understand, okay, the drug has a price, but once it gets to the provider practice, what are we talking about as markups? Now, the House budget includes a provision for the HPC to look into some of these issues. We think that's important, but there's probably more that the HPC can be doing in this space. And the last piece, it sort of touches upon some of the stuff that Paul had talked about in the role that the HPC can play as a convener, and I think about it in the context of comparative effectiveness. Now, one of the big issues that the plans ran into when Sovaldi hit the market wasn't just the issue of price, although that was a big issue. It was also the fact that we had this new drug to market that didn't have any real clinical guidelines. And there was a whole lot of sort of searching around in the dark as to who's best appropriate to receive this drug. And there was work that was done with the plans in Mass Health to try and provide some context around that. You know, similarly, you guys are now sort of dealing with that issue around Spinraza. I think there's, so rather than having sort of this piece, the downstream impact, where OPP deals with external appeals, and then by default, we come up with some sort of rules of the road around particular drugs. There might need to be something more on the front end as we see new drugs to market. What's bringing plans, providers, others, and independent entities like ICER into the conversation to help set up some sort of rules of the road as to here's where, here's the type, here's the drug, here's who it's best for. The Spinraza is a perfect example of this, that while the FDA has approved it for all 4 categories, there's only been a limited amount of analysis and clinical trials done in certain categories, and I think that's an important piece that you guys are going to be grappling with as external reviewers, but also things that payers and providers will be dealing with on a going forward basis.
Thanks, Eric, and many of those are fully consistent with the recommendation we have in the cost trend support. This is an issue that's not going away. I'm going to do one last round of the room for the people who hadn't had an opportunity to jump in. John.
Thank you, David. I guess I would follow up a little bit there, not necessarily on pharmaceuticals, but certainly in cost. And costs for employers, for consumers, and taxpayers. And I, you talk about efficiency, and that's important. But this is a non-political group organization. Should be free of some of the political concerns that often happens in policy making on healthcare, which is, we all know, a very powerful and large industry. I just wonder if there is a role here that HPC, as you look at cost, are you looking really at the infrastructure? Is the infrastructure adequate? Is it excessive in certain areas? Is it what the consumers should be paying for and the taxpayers should be paying for? Or are we not allowing things to happen like it happens every day in my industry, thanks to these things that, stores and restaurants close down every day. Sometimes you read about it, sometimes you don't. But are we allowing, is the industry evolving the way that it should? Are we protecting interests that really we shouldn't be protecting and can't afford to protect anymore? And there are other government-imposed issues as well. Are we sometimes discriminating against certain consumers just because of the size and where they buy their coverage and the risk pools that they're in and the tools that they have and the state mandates that they have to pay for and others don't? There's a lot of things that go on government policy-wise that hurt particularly certain consumers and certain taxpayers. And these are things I think this commission should be looking at.
Thanks, John. David? John?
Yeah, I'll try to be quick. This is my first meeting, so I was going to be quiet, but what the heck. There are no HIPAA violations. I just want to assure all of you that this is very, very nice thing. You have good counsel. What I'm finding fascinating in listening to this is, I've heard these conversations for 40 years. Fragmentation in the healthcare industry has been a long issue, and I would guess that everybody around here in the area that they're in knows what you could do to fix it. The problem is our reimbursement system doesn't encourage it, doesn't incentivize it. It's a fragmented system, it's a fee-for-service system. I always use the analogy, it's like buying a car by going out and buying the parts, and then putting it together yourself. And that just doesn't work. We wouldn't be having this conversation in any other industry, because the industry would be based upon consumers, educated. We're getting there in the education. That's what was missing for a while, but educated consumers making value decisions. And if they choose good, we all have good quality. If they choose good quality, high cost, or good quality, low cost, doesn't make any difference. Deductibles don't work, co-pays don't work. To go to John's point, and then I'm going to get to actually support John and his businesses, the parts of the system we lose are often the parts of the system that we shouldn't be losing. We've got more academic medical center beds in Massachusetts than any other state in the union. We haven't lost any academic medical centers, but we've lost an awful lot of community hospitals. So unfortunately, again, that fragmented system, fee-for-service system is actually pushing out those things that we need and keeping in place the things that maybe we don't need as much of. The last point is, as we sit around as clinicians and people who advise clinicians and talk about how we could do things better, that's all very well and good, and we all want to do good because we do good. But unless we do two things, number one, go back to Stevie's point, we move out of fee-for-service into risk, because that's part of it. But all that is sort of the cost side. It's the provider side. Okay, I can get a little more out of this contract. I can get a bigger chunk of the holdback or the withhold or the incentive if I do this better, until we get to the consumer side, until we can pass those savings on. John,
it's really hot. Can you please put the air conditioners in?
Market's not going to ship every
Man, this thing is heavy.
Honey, don't hurt yourself.
If you're same quality,
These things are heavy, noisy, and expensive. Central Air is quiet and comfortable.
I love our new AC. We're always cool.
And it saves me all that work.
Rich boards, folks. You know, we're just engaging in academic exercises. We've got to translate that into actually making healthcare work like a normal marketplace. End of my speech. Thank you for having the honor to serve.
Jeff?
Thanks, David. As far as what the HPC can continue to do with regard to life science and biopharmaceuticals, just keep your doors open like you always have. We're working on a lot of these issues with you and other folks around this table, and we'll continue to do that. Two of the issues that I think that we've seen, and you've seen, David, that in your staff and your team, like at Mass Bio, we participated in a knee-high group, think group with Mass Bio, and I'm hoping that you're somehow dialed into some of these outputs. I think a white paper is coming out soon. I'll ensure that happens as well. But as a member of the industry, you know, dealing with value-based contracting, dealing with some of the things with the programs and algorithms and treatment protocols that Eric just brought up, I mean, I think that's a slow but sure process, but that can help, I think, some of the guidelines and maybe even address some of the issues that Dr. Broke talked about in terms of waste in this particular market. People not taking their medicines or not having access to them are probably the two of the big wasteful issues in our industry, right? And lastly, just on the HPC cost trends hearings, I mean, David, this is something I think you and I personally have been talking about for the better part of 2 years. So this is the year actually that it does happen, whether it's mandated or otherwise. You know, I'll make the commitment, not on behalf of AstraZeneca or the industry in terms of who that person will be or people, but if it's going to happen, let's lean into that one and continue to talk about it and put my colleagues and our organization on notice that this is intent. Let's lean into it, and it's going to take some thought and I think some clearance internally and a lot of these issues that come up, particularly as we work now more energetically with the CHIA group and our colleagues on the rebates and discounts and who, what company and what we're comfortable with talking about at those hearings. And that's something that we'll continue to discuss because it's not something that we've been avoiding, we've just been trying to figure it out. So that's our commitment.
Thank you. I look forward to that continued constructive dialogue. Alyssa?
So I'll also be brief, but just a couple of things. So first, I want to say that it's fantastic to hear social determinants of health mentioned in this room. You know, it was a topic of the cost trends hearing last fall, and I think something that hasn't been part of the conversation in a regular way up until now. So that's really, it's really promising. And I think a couple of the ways that the HPC could specifically contribute to that conversation is I know you don't have an incredible opportunity with the Mass Health ACO program and the ability for Mass Health ACOs to use flexible services money to address social determinants of health. And I know Mass Health is looking for, you know, sort of proven ways that this has really, that this has worked. And I think the CHART program is one way that, you know, we can kind of share some best practices on the ground about how it's worked in this state. So I would just encourage the HPC to keep those lines of communications open with Mass Health in that area. And as well as look at the existing ACO, the HPC's ACO certification process. I know there's, you know, sort of some ways to get social determinants in the standards. I think we would like to see those go further, but I think it's a good first step. And so to be, you know, looking at how to use that as a model as well. The second piece is I'll say we would echo what Eric said in terms of looking at pharmaceutical spending, and I think we would pretty much support the three suggestions he had. Another piece of it that we've been promoting for some time now is looking at a program called academic detailing, which is evidence-based prescriber education. And I think that the HPC could also play a role in promoting that in the state. The third is around transparency and the event that was held earlier this week. I think it was really great to have a whole event focused on some of these demand-side incentives, and a lot of the evidence that was presented reinforces what we hear on our helpline all the time from consumers in terms of not understanding, sort of cost and quality information and not really being able to make informed decisions that would sort of steer their decisions based on where to access high-value providers, and it was encouraging to hear sort of consensus in the room about the fact that, these quality measures have to be meaningful, and I just feel like we've been hearing this again for years. And so anything that HPC can do in that space to really figure out, how to ensure that not only are the cost differentials enough to make, consumers make certain decisions, which we know is important, but the quality piece is also really, really crucial. So I'll stop there.
Great, thank you. All right, I think you have the last word. So thank you all for this conversation today. I know we went over, I promised you an hour and a half, and we ended up closer to 2 hours anyways. Really, this was an excellent conversation. I will bring back your thoughts to the board. If you have other thoughts, please contact us.